A is for airway, airway part 2. In healthy individuals, the airway automatically stays open. We don't have to worry about it. But if somebody becomes injured or positional, laying flat on their back, then that could cause a problem for them. So when we come up to somebody, we check for responsiveness, one of the first things that we'll do. If we think there's trauma, and we'll learn this in the trauma section, we'll have somebody hold the head in a neutral inline position. We call that cervical spinal immobilization or management. So we gently tap them. We try to touch them as we speak to them. We say, "Are you okay? Can you hear me?" We say something like that. If I walk in the room and somebody's looking at me, I'm not going to run over and shake them. I'm just going to go, "Hey, I'm Susie with EMS. How can I help you?" And we get an automatic response. We say that they're awake. If they look like this, though, I want to tap and shout and see if I can get them to respond to me. I may use painful stimuli to see if I can get a moan or a groan or somehow for them to let me know that they're okay, at least breathing or something. Then, like that one in the picture before, laying on their side, I want to position them on their back. Now, it's up to you if you say, "Oh, I'm going to go ahead and put a board there so we can easily move them," but position them on their back so you can scan the chest quickly, just seeing if somebody's breathing, and y'all practice that in class with your vital signs, and then check for a pulse. If they are unresponsive, I'm going to check for a pulse in the adult and child in the carotid artery in the neck. If they're unresponsive and it's an infant, I'll check in the brachial artery in the arm or the femoral in the leg. But if somebody's awake, I won't be so intrusive. I'll just grab a radial pulse in that adult. So if they have a pulse, yay, then I'm going to go back and look at that breathing and say, "You know what, I really didn't notice that they were breathing that much. Let's check that," and then we'll start with our airway. So if they're not breathing, I need to first off see if it's just a blocked airway. Maybe it's something really simple. So an ex-partner of mine and I went on a call several years ago. A little girl, she was probably about 11 months old, I'm sorry, and barely toddling, and they had cloth diapers. That's how long ago it was. Nobody has cloth diapers anymore. And they had, when you have cloth diapers, you scrape the stool into the commode, and then you let the diapers soak in this chlorine-filled bleach water. To let them soak, until you had enough for a load, then you wash the diapers. Well, she took the lid off, she fell upside down into that bleach water. She probably kicked for a little bit and then stopped kicking and stopped breathing. So family pulled her out, called 911. The whole way there, I'm thinking about advanced stuff. Oh my gosh, what are my drugs are going to use? How much does a child weigh? How about an airway? Can I get the advanced airway? Everything. So we walk in, she's lying on the carpeted living room floor, and the carpet's blue. She matches the carpet. She's just like a smurf, just really cyanotic. And I start opening the bag and getting out all this fancy equipment, all this advanced stuff that I'm going to need. I'm still thinking about how much drugs is she going to need because we have to calculate it by weight. And my partner reaches over and he opens the airway. He tilts her head back. She opens her eyes. She takes a deep breath and she starts crying. Problem solved. We didn't have to do all that fancy stuff. We had to just do step by step by step. So as an EMR, you may think, "Oh, we're not going to be able to do much." Well, an EMR would have been able to handle that call. And a lot of times, all calls start, number one, with BLS, but a lot of times that's all you need. So one hand on the forehead, other fingers under the bony part of the chin. Be careful not to put your fingers on the soft spot under there. And you're not really closing the mouth. You're just supporting it. The head on the forehead is going to do most of the work. You tilt them back in a sniffing position. What's a sniffing position? Say you come home and somebody's made brownies, and think about what you do, how you tilt your head back and you go, "Brownies." That's sniffing position. Now, if you suspect a neck injury, they've fallen out of a tree, they got hit by a car, they fell off a horse, whatever it is, you suspect a neck injury, you can't tilt the head back for fear that there could be spinal cord damage, especially in the neck. So what we're going to do is get at their head. If I'm at the head of the victim, I own the airway. That is my job. That is my only job. So I'm going to take care of airway and breathing there. And what that looks like, boy, I sure thought we had a picture. Okay, you know what I'm going to do? In the next section, I'll add a picture and I'll talk about jaw thrust because this is that important to be able to do that. You're going to practice it in class. But what you're going to do, and do this on yourself right now, just relax, put your fingertips behind your lower jawbone, and then push it forward towards the front of your face. Just relax your jaw and let it push forward. You look like a bulldog, I guess. If you have TMJ, don't do this because it'll hurt. but your tongue's attached to that lower jaw, and by doing that, you're lifting the jaw off the back of the throat. I apologize for not putting a picture in here. I sure thought I saw one, but I'll add one at the next section so you'll get to see it. Other things, so that's airway positioning, and that's the two things you need to do to position the airway. The other thing is sometimes there's vomit, sometimes there's mucus, just saliva. You go to the dentist and they're working on your mouth and you're like, I'm drowning in my saliva, please suction me. And then finally they do, you're like, well, thanks. Sometimes blood. Sometimes foreign objects. Now, foreign objects are not the tongue. The tongue belongs to you. Foreign objects such candy, lifesavers. Wow, you ever thought about lifesavers? They have a hole in the middle. And that's because you can't choke on a lifesaver. It's got a little hole in there so you can breathe through it even if you choked on a lifesaver. Food, dirt, dentures. If dentures are good fitting, leave them in. If they're not good fitting, take them out. Don't put them in your pocket. You'll go home with those things, and those are nasty. So, plus they want them back. You know, people want their teeth. So anything you find in the mouth, if you see it, you can reach in there and get it out. Make sure your victim is unresponsive before you put your fingers inside their mouth. Finger sweeps can be done. So the rule of thumb with this is if you see it, you can pull it out. So say somebody ate a taco and they choked on the fajita meat or something, and it's real gristly, and that's a common thing for people to choke on, especially if there's alcohol involved. And if they're unresponsive and you see it, just with your gloves, you can reach in there and pull it out. And then everything else that's like blood, vomit, that kind of thing, we'll use a suction machine. So suction can be manual devices. I was never a big fan of these until, you know, you have to carry around a portable suction unit. Then you're like, well, you know, these aren't that bad. So they squeeze, or they're hand powered pump. And it's not a bad deal. They're not as good as, you know, something that sucks at 300 millimeters of negative suction, but still in a pinch they work pretty good. Mechanical suction units, these are mounted in your ambulance, or they're portable. You can take them out. And as long as they're battery operated or oxygen operated, they work. So you want to turn the device on, and we use either a rigid suction tip or a soft suction tip. And the rule here is don't suction for more than 15 seconds at a time, and it shouldn't take you longer than that to clear that airway. I like using suction devices with the person's head turned. A lot of books still keep the patient in a supine position. And I think, well, if they have fluid or something in their mouth that's potentially going down the back of their throat, you know, the fastest thing I can do is put them on their side. So I still like side. I don't think National Registry is going to test you much on that, but for real world, I think it really helps. If they do have vomitus that's seeping back into their airway in the trachea, have you ever had a burp, you know, like a vomit burp, and it burns your throat? Well, think of all that acid going down into your trachea, into your lungs, and we call that aspiration pneumonia. Has a very high mortality rate. So that's why I like turning them on their side, which brings us to the next slide where it says recovery position. So if somebody's unresponsive and you're waiting for help, you're the first responder, and they've called for help, an ambulance is coming, you're like, well, what can I do, what can I do? Well, he's unresponsive. If there's no evidence of trauma, roll them over on their side. That way, if there is any secretions, gravity will help it just flow right out. And there's a great picture of a recovery position. So you don't need all this fancy equipment to just say, well, they can't protect their airway because they're deeply unresponsive. So I'm going to roll them over on their side. There you go, recovery position. Now, you've opened the airway with the head tilt, chin lift, and jaw thrust. But now you're kind of stuck doing that, because if you let go, they go back to a neutral position. I know you're going to be playing with the mannequins, and you can tilt their head back one week and walk away and come back next week, and they're still in that same position. They don't move. Real people do. So we can use oral airways that go into the mouth, or nasal airways which go into the nose. The oral airways are quite easy. You just have to use some caution with them. So they're for people who are deeply unresponsive. How do I find out they're deeply unresponsive? Because they can't have a gag reflex. So I can do one of two things. If I put it in, and you know the molars, when you're brushing your molars in the back of your mouth in the morning, and you hit them and you go, ah, ah, that's your gag reflex. So that's one way of checking. You put the oral airway in, and they go, ah, okay, and then you roll them to the side so they can throw up and you can suction. Wow, that's a mess. Or you can tap their eyelids. Don't flick them, just lightly tap their eyelids, and if they don't flinch at all, they probably don't have a gag reflex, because a lot of the nerves that the deeper unresponsive we get are much the same. That's one way to find out. They're shaped like this because they follow the curvature of the tongue. So when we put these in, we want to make sure we get the right size. We measure from the corner of the mouth to the earlobe. And then I want to insert in a rotational process, I guess is a good word, which we'll learn in our skill drill next week. So this is a lot of fun. It keeps the airway open. Now I can't insert one of these and then walk away. I need to stay with that victim because if they regain their gag reflex, they're going to choke on this, vomit, aspirate, and die. So you need to stay near them. These are called nasal airways or nasal trumpets, and they're designed to be fit into the nose. And you see that the bevel at the end, at this distal end down here, see if I can point it out, is tapered toward the septum. So if it goes in the right nostril, it fits like it should. But just look at the nostrils and see which one it would fit in. It can be used in both an unconscious and a conscious patient. And it's not supposed to stimulate the gag reflex. We put them in on each other at class, and it kind of does. If it does, just pull it out a little bit so that it's not back that far. You need to lubricate these with a water-soluble gel like KY jelly. And then just kind of twist them as they go in. I like these. We measure these from the nose to the earlobe, tip of the nose to the earlobe. Put your water-soluble lubricant on it and just look and see which nostril it would look like it fits better in. Push it all the way until the flange fits on the patient's nostril. So you'll put these in skills. That's airway. Let's move into breathing. So looking at ABCs, breathing, to know if somebody's breathing adequately, where they have a normal rate and depth, not making any noise, and it's a regular rhythm. I breathe in, I breathe out. They may still need oxygen though. Versus somebody who has inadequate breathing, okay, they're breathing too slow, or they're breathing too fast, and then their depth isn't good. Maybe it's too shallow. Maybe their rhythm pattern is irregular. They breathe 18 times a minute. Woohoo, that's great. But they breathe 18 times in 10 seconds and hold their breath for 50. That would make it irregular and also inadequate. So these people would need ventilation. They need us to breathe for them. And here, this is very complex. I'm going to try and explain it very simple because it will help you understand whether or not they need ventilation. So this thing called minute volume is called how much air we move in and out in 1 minute. So each breath is called tidal volume. The tidal is the amount of air we breathe in each breath. We multiply that by the respiratory rate. So let me give you an example. Say that average tidal volume for an adult is 500 milliliters. So your can of soda is 455. I say can of soda, it could be a can of beer, it could be a can of anything. 500 milliliters of fluid. And I think they're 455. So about that. That's tidal volume times a resting heart rate of 18 breaths per minute equals 9,000 milliliters or 9 liters a minute of minute volume. So that's how much air you move in 1 minute. So if somebody's breathing shallow, maybe only 300, you can barely see the chest rise. And slow, maybe only 12 breaths per minute. So now they're only breathing, what I say, 300 times 12, 3,600 milliliters, 3.6 liters, or almost a third of normal minute volume. See how that works? If you have shallow and slow, they're not getting the air down to the alveoli, and they're not oxygenating the body. So slow and shallow are going to need ventilations, even though they're breathing, even though it's just on the slow end, but those two together are two negatives, and it makes for positive ventilation. I hope that helped explain it. Listen to it a couple of times, do some math, play with some numbers, maybe it'll make it sink in. Signs of adequate breathing. Well, we look, listen, and feel, so listen to yourself breathe. Are you making much noise? You can actually see people's rise and fall of the chest, and you can feel the air moving on the side of your face if you put your face down there near their mouth or nose, whatever they're breathing through. And most people are nose breathers. Normal resting breathing rate is 12 to 20 breaths per minute. Signs of inadequate. Well, they're making noises. They got stridor or wheezing or gurgling. Gurgling, think of gargling. You know, they got fluid in their upper airway. They're breathing too rapid or gasping. So have you ever gone fishing and you caught a fish and then you throw it up on the bank, you're still deciding if you're going to keep it or throw it back or whatever. And the gills are just going in and out, in and out, in and out. And the fish is looking at you going, wow, you don't have gills, and you're breathing with your mouth. You're all excited. So the fish goes, we call that guppy breathing. That's agonal respiration. So gasping respirations are not really breathing. It's just agonal, going, gone. So look at those. If the skin changes colors, if it gets too pale, then that means there's not enough blood in that area. If it's blue, there's blood but no oxygen. And the most critical sign of respiratory arrest is you don't see chest movement, you don't hear breath sounds, and you don't feel any movement to the side of your face. Some causes of respiratory arrest could be a heart attack, could be a foreign body airway obstruction, or the tongue blocking it. It could be vomitus, especially from somebody that has not the ability to protect their airway anymore, can't swallow, like a stroke. The foreign objects, or disease. Drug overdose, that's very common. So especially kids, they try things and they're like, hey, try this. And the kid takes it. You know, they don't even question it. And next thing you know, they're not breathing. Somebody that gets poisons, lost a lot of blood, or electrical. So when we check for that, somebody that's lying motionless, shake and shout, look for movement of the chest. Check a pulse. If the pulse is present, then come back to the breathing and go, okay, we got to take care of the breathing. We have to correct it. Now, this tells you how to do mouth-to-mouth resuscitation. Pinch the nose, take a deep breath, not too deep. You're not blowing up your kid's raft. You're only causing the chest to rise. And blow into their mouth for 1 second. Make sure you have a tight seal. As they exhale, make sure you remove your mouth and move away a little bit. If they're going to vomit, they're going to vomit on exhalation. You don't want your mouth to be right there. Wait a second and do it again. You're going to do this about every 5 seconds. You want to count to yourself. You don't want to breathe too fast. You don't want to breathe too deep. That's what you're going to do. Well, I think that's just gross. I've never done mouth-to-mouth in 34 years of doing this on an adult person. I did it on a child, but not an adult. I think that's gross. My very early years, my partner did mouth-to-mouth on somebody with all the white stuff at the edges of his mouth. He's like 80 years old. Kind of looked like this guy. That's why I picked that picture. That's just gross. So mouth-to-mouth, mouth-to-mask rescue breathing is better. You get a good tight seal with the mask. You're at the head, so you get to put 2 C-clamps on that mask. We'll talk about that with BVM. 2 C-clamps on that mask. Use 2 sets of hands with the E fingers underneath the chin, pulling it back. No cross-contamination. Plus, you have a one-way valve. That's excellent. You can use barrier rescue devices. Those are pretty cool, too. Just some kind of thick plastic film that covers a face. You know, it protects you somewhat from infectious diseases, but not 100%. There's your mouth-to-mouth rescue breathing. There's your mouth-to-mouth rescue breathing, not mine. Carries a somewhat higher risk of contracting a disease, it says. Yeah, so reserve this to somebody that, I reserve it to somebody I sleep with. You don't sleep with them, don't do mouth-to-mouth. Bag mask device is very good. You get a nice seal with the mask, and then you squeeze the bag. I will tell you that this sometimes is very hard for one person to do. Remember the pocket mask, that mouth mask? You got to use 2 hands to secure the mask, and now you're only using 1 hand because the other one's going to squeeze the bag. So it's better to have 2 people do this. See how he's got 2 C, the letter C's around the mask, and not so much pushing the mask down on the face, but lifting the face with those other 3 fingers under the jawbone into the mask, and then the other person squeezes the bag. Plus, you can help each other count. They've got little devices, impedance devices, which go between the bag and the mask, which are great, and they light up every 5 seconds, so it keeps time for you. Those are amazing. A little bit costly. So a little bit on airway breathing review. You see somebody that appears to be unresponsive, touch them, shake them, and say, are you okay? If they're unresponsive, you're going to need backup. If you're, I always thought this was funny. We teach you how to be EMS, and then we say, call EMS. Well, I thought we were. Well, yeah, to a point. But if it's just you and your partner, you're going to need backup. If you're a first responder, you're going to need EMS. Roll them over on their back. Quickly scan them for breathing. And at the same time, check for a pulse. Carotid artery in the neck, one side or the other, not both. If the pulse is present, woohoo, we've got a chance here. Then you want to go back to your airway. Check and make sure it's not a blocked airway. So open the airway, head tilt, chin lift, or the jaw thrust if they have trauma. Look in the mouth. See if there's any secretions that you can see. And if they're unresponsive and you see something that you can grab, clear the airway. Then maintain that airway by putting something in there, either an oral airway or a nasal airway, to keep it that way. Listen now for breathing. Look at the chest. Listen with your ear. Feel for air moving to the side. If they're not breathing or not breathing adequately, we don't have to wait till they get to zero. Then use some kind of barrier or a bag mask device and breathe for them. We told you before, the smaller somebody is, the faster they breathe. So you're going to breathe maybe one breath every 3 to 5 seconds instead of 5 to 6. Plus, they're smaller. So lessen the amount of volume that you give. As you breathe, you should look for the chest to rise and fall. And all you want to see is what we call visible chest rise. You barely see it moving. I mean, think about it. They're not running a marathon. They don't need to be breathing real fast and deep. They're resting. For infants, it's even smaller. If you had to do mouth-to-mouth on an infant, because their nose is so small and broad, it's broad like that so they don't suffocate when their mother breastfeeds them. So it's hard to pinch. So just cover all of their mouth and nose with your mouth and just a little puff of air. Causes of airway obstruction. The most common is the tongue. So head tilt, chin lift, or jaw thrust, depending on the situation, gets that tongue off the back of the throat. But a foreign object is going to be food, and we need to remove that food from there. So it shows the tongue drop blocking on the top left. It shows injury here. There's some kind of crushing obstruction. A foreign object, a little thing sitting right here that we can get out, hopefully when they're awake with abdominal thrust. If they're unresponsive like this guy, they're going to just get circulation to the brain. And then an obstruction from swelling. It's a good stopping place, so we can continue on with part 3.